So welcome and good afternoon, ladies and gentlemen. Welcome to this launch of the Lancet series on optimizing child and adolescent health and development series. And I'll have an opportunity to say a little bit more about this. But without further ado, let me welcome everybody who's in this particular auditorium and also joining us online. And to get us formally started, it's my great privilege to introduce the Provost of the Aga Khan University, Professor Amrhein, who became the Provost and Vice President Academic of the AKU in 2017, and prior to that has held leadership positions in the University of Toronto and the University of Alberta, and has contributed significantly to governance and professional development in education and health services globally. So without further ado, Carl, the floor is yours. Kindly welcome everybody to the AKU Institute for Studies of Muslim Civilization. Thank you.
Thank you, Zulfi. Good afternoon. Hello, bonjour, assalamu alaikum, Karabun. Welcome to AKU and welcome to AKU ISMC. Provosts get to do many, many things, and now I get to tell you where the washrooms are. The washrooms are out the door over here to your left and around. Point one. Point two, it is Ramadan. If anyone would like to pray, we have a quiet room which has all of the facilities for your prayers. Also to the left, it is the door labeled reflection room. I need to inform you that we are not expecting a fire drill today. So if you hear the fire alarm, it's for real. And we then invite you to leave the building down the stairs in a calm and orderly, unacademic way. And the fourth point, there will be coffee and biscuits served afterwards. I assume that means after the session, not after the fire, but my notes are not clear. So that's part one. Part two, it's my great pleasure to invite you to this session. Since its inception, the Aga Khan University has embraced a global mission seeking to unite the best of scholarly research with large populations that remain in many instances all too neglected. From our founder and chancellor, His Highness the Aga Khan, we have a four-part mandate. It is to make sure that all we do has impact, is conducted at the highest standards of quality, is relevant to the people in the countries we serve, and is accessible both in education and in healthcare, regardless of ability to pay. We are a small university with a relentless focus on academic excellence. We work in 6 incredibly diverse countries, frequently under highly challenging conditions. Nonetheless, the caliber of the work of our faculty, as will be on display today, is very high. There are few examples of successful global collaborations in scholarship and international policy influence that can surpass the impact of the contributing authors of any Lancet series. This series on optimizing child and adolescent health and development will be no exception. And in honor of the series launch, with us here today, we have the people who are responsible for this effort, and we will hear from them in due course. Despite recent progress, with only 8 years left to meet the UN Sustainable Development Goals, the world is at risk of failing to meet child and adolescent health targets. Never has it been so important for environments of eminence, like all of those here, to unite in interdisciplinary and longitudinal research. The Lancet series seeks to go beyond the usual consideration of children's health in silos, for instance, newborns or children under 5, and make the case for building comprehensive and holistic care, spanning nutrition, preventative health, education, economic, and community support across all age groups from preconception through age 20. The series also acknowledges the additional challenges created by the recent COVID-19 pandemic, challenges that will retard our ability to meet the SDGs, increase children's vulnerability to violence, and create mental health conditions that need to be acknowledged. The Aga Khan University has a long-standing commitment to the UN Sustainable Development Goals. This is evidenced by a wealth of scholarly research. For example, since 2015, AKU researchers have published more than 1,900 articles related to SDG number 3, focusing on good health and well-being. Many of these consider key issues around child and adolescent health and welfare. Considering the research results posited by the author of the Lancet series, we are at a cusp of interesting and impactful health research developments, and gatherings such as these help signal new and evolving approaches to researchers all over the world. AKU is 39 years old last month. Throughout our history, we have focused on issues confronting women and children, issues of empowering women in their communities, creating career opportunities for women. In both Pakistan and East Africa, our schools of nursing and midwifery were the very first academic units established by His Highness. Maternal and child health research has been our single largest pillar of research. Stunting and nutrition is a series of topics that we aggressively pursue. All of these are part of our legacy. What comes next? I note in the material circulated for these meetings several references to the roles of schooling and formal education in your work. Our colleagues in our institutes of education are turning their attention to the rapidly increasing numbers of young people in our countries with no access to formal schooling, formal education. 2 statistics. It's estimated that in sub-Saharan Africa, 36.3 million children will never have access to formal schooling. In Pakistan alone, it is estimated 22.8 million children will have no access to formal education. In our countries alone, the countries of the Aga Khan, not including UK, of course, over 59 million children are at risk of having no formal education. What does this mean in your work that so obviously and reasonably relies on using formal education as the vector of intervention in improving childhood nutrition and the quality of life? Perhaps there's another Lancet series in the offing here, the intersection of the absence of formal schooling and health and welfare. So as I yield the floor to my amazing colleague, the coordinator of the series, Professor Zulfiqar Bhutta, recently the winner of the Rue Prize, and even more recently, the winner of one of the intensely prestigious, coveted, magnificent Gairdner Prizes. And I say that not just because I'm Canadian and we are irrationally proud of the Gairdner Prize, because I was born in Pittsburgh. It's because it is one of the 3 really big ones. So I'd like to acknowledge Professor Bhutta and all the work he has done in improving the lives and welfare of women and children in our countries and around the world, and also all the work he has done in building AKU. The rumor has it that he laid the cornerstone of the first building as a teenager going to high school, and he just simply has never left, but we'll let him clarify that himself. So I hope you enjoy today's discussions, and I hope you all follow with great interest the work of the Lancet series, this and all of the others. And I thank you, those of you in the room, for coming to AKU. It is fantastic not to have everybody on Zoom. And I remarked a number of times how very different people look other than on their Zoom profile. So to those of you in the room, thank you for coming. For those of you on Zoom, find an opportunity to travel. It's not as painful as you might think it is. It's just a little bit of paper. Thank you and good day.
Thank you very much, Carl, and thank you for those kind words. To those in the audience and in the wide blue world who are wondering, I do wear two hats. I've been at AKU as one of its founding faculty members for over 36 years. And I also wear the other hat of my second home, which is as the co-director of the SickKids Centre for Global Child Health. And it's important to point that out because the effort that we're going to share with you today represents a fantastic collaboration between institutions, individuals, and also across continents with academic centers. So I've been greatly privileged to have played a role as the series coordinators for this particular series, which was almost 4 years in the making. We conceived of this series with an initial meeting that Bob and Cesar might recall was partly in person and partly by Zoom in early 2018, before people even realized that Zoom would take over our lives. And we planned a lot of this work at that time with a time frame that was much shorter than what it eventually became. So the series that you will have, and if I can have the next slide, please, and move them, is an academic collaboration between a number of centers. Can I have the next slide, please? Okay, well, let's go back. So academic centers such as the Aga Khan University and University of Toronto, SickKids Centre for Global Child Health, Johns Hopkins University, Howard Chan School of Public Health, International Center for Equity in Health at Lotus, Research Triangle International, University of Melbourne, and a special call out to my dear friend is in Melbourne who are very much part of this, George Patton and Susan Sawyer, and to T.S. Boerma and Countdown to 2030, who were a very essential part of this effort from the very beginning. So the work took a bit of time, and for us to organize this and to have this as a worthy successor to the Bellagio series that Richard will elaborate on, we actually did reassemble in Bellagio in September 2019. And I'm very grateful to Jocalyn Clark, who's in the audience somewhere. Here you are, Jocalyn, who was with us in person in Bellagio as we assembled an advisory committee to help us guide through what this series would look like. And we spent a few days just deliberating on the various elements that we would cover before the world turned upside down. A couple of months later, with the pandemic that came upon us, and with the pandemic, all of the work had to be done remotely. So I'm absolutely delighted that we were able to deliver and produce a set of papers that had to be done through collaboration, largely done virtually. And many of the people who were there in person are also here in person today, who will take you through various elements of this work. I want to specially call out one person in this group photograph, and that's our dear departed friend, Pete Salama, who came down from Geneva especially to spend time with us in Bellagio. Pete was a unique individual, and I want to remember him today in particular, not only because of his enormous contributions to children and child health worldwide, in all kinds of settings, including conflict settings, emergencies, in areas where his leadership when he was at UNICEF was critically important, but also because he came and spent time with us in Bellagio because he understood the importance of looking at childhood across the continuum, from early life to school-age children to adolescent and beyond. And in his legacy will hopefully emerge from this series because his contributions are enormous. He came in his official capacity as WHO, as one of the senior members in WHO, at that time when he was beginning to embark upon the planning for implementing universal health coverage. And I want to particularly call out WHO's partnership in this endeavor through the work that has received attention, support, both in spirit and in kind, and also in material manners. And I want to thank my friend Anshu Banerjee for providing concrete support to make it possible for us to address some of the issues around school-age children in this series. And this is a good segue to introduce the the Director General of the World Health Organization, Dr. Tedros Ghebreyesus, who could not be with us in person, but he has sent us a special message that we will play shortly. Dr. Tedros, to many people who don't know, was elected as the Director General of the World Health Organization for a 5-year term in 2017. So this is the year when he will hopefully receive his renewal to the second term. But he comes from a phenomenally important background of having served as the Minister of Health and the Minister of Foreign Affairs in the government of Ethiopia, and also a number of international bodies, including the Global Fund to Fight AIDS, TB, and Malaria, Global Fund as it's commonly called, chair of the Rollback Malaria Partnership, and from a very early stage when I was a member of the board as a co-chair of the board of the Partnership for Maternal and Newborn Child Health. So I'd like to yield the floor to this message from Dr. Tedros.
Dear colleagues and friends, with less than 10 years left to meet the Sustainable Development Goals, the world is at risk of failing its children and adolescents. Conflicts, the climate crisis, and the COVID-19 pandemic have aggravated existing inequities and keep more than 1/3 of the world's children from realizing their potential. Many health systems still struggle with offering holistic care that spans sexual, reproductive, maternal, childhood, and adolescent health, as well as nutrition and development. The lack of access to quality health care, safe water and sanitation, clean air, and opportunities for learning put entire generations at risk. 6.5 million children and adolescents under 20 years died in 2020. Most of these deaths were preventable. This new Lancet series provides the evidence for life-changing concrete action. Early investments in children and adolescents' health, education, development, social welfare, and protection have lifelong, intergenerational, psychosocial, and economic benefits for children and societies. It's also time to support macro-level reforms such as school health and nutrition services, social protection, adequate housing, and community support. Primary health care is not only a gateway to universal health coverage, but also provides a platform for multi-sectoral action. I thank the authors of this Lancet series and the Lancet editorial team for their relentless efforts to keep children and adolescents in the spotlight. I thank you.
Thank you very much, Dr. Tedros, for making time to send us this special message. And now, ladies and gentlemen, I will introduce a very special guest and friend, Richard Horton. So, Richard, to many people, is this formidable chief editor of The Lancet, who has been the voice for the global public health conscience for many, many years. But to us, Richard would always be the friend who arrived in Bellagio 20 years ago almost, to serve as a partner as we embarked on the first child survival series that you will hear about. And at that time, nobody had a faintest idea as to what a series was and what would a few papers do for global health. And I'm sure there'll be an opportunity to introduce and talk about that contribution. But Richard has been an icon in global health in many ways, not only because of his leadership positions in many initiatives. He was the chair of the Independent Expert Review Group for looking at progress for maternal child health, and a relentless taskmaster, because I was also a member of that group and knew how he led from the front. And he has also been a steady voice calling for scientific leadership rigor and looking at the most difficult issues during the COVID pandemic. So if those of you who want to read about what went wrong and could have been done better, read his book on the COVID-19 response, because there is a lot of insight into how we could do better in global health. He's highly rewarded. In addition to the Room Prize that he received in 2021, he also received the Physician for Human Rights Award, Richard. So it's my great pleasure to invite you to come and give us your thoughts and to also in turn introduce the UNICEF Executive Director. Thank you.
Thanks. Well, that's very, very sweet of you, your words. And it was fantastic to see Tedros up there. The last time I saw Tedros introduce anything for the Lancet, it was literally February 2020, the month before we all went into lockdown. And that, Anthony, of course, was when we launched our commission, which I'll mention briefly in these few opening remarks. Now, I'm supposed to say something about the genesis of this series, and the truth is that this series actually began 20 years ago. This was the first child survival series that we did, and it is so lovely for me to see Sarah Bennis and Jennifer Bryce sitting in the audience, because it's thanks to, first of all, Sarah, who'd been to a conference in New York and had met Jennifer and came back to our Lancet offices and came to me and said, Richard, you've got to meet this woman. She's amazing. Okay. And then Jennifer came over, and Jennifer totally shamed me by saying that you claim the Lancet is an international medical journal, and yet you have done nothing and you know nothing about one of the greatest shames on the modern history, as it then was, of the world, and that was the over 10 million under 5 deaths, most of which were entirely preventable. And so from that came this first series. And in the history of the Lancet, it's achieved somewhat mythical status, to be really honest, because that was an inflection point for us in our work. It inaugurated 2 decades of trying to link science with policy and sometimes even politics. And it's to Jennifer and Sarah and that team of authors from the first Lancet series and the 5 papers that they did in 2003 that I do want to pay special thanks to, in addition to the authors of this latest series, because without them, we wouldn't be here now. Now, that series is also important to remember because it inaugurated a second child survival revolution. The first, of course, led by Jim Grant, Executive Director of UNICEF between 1980 and 1995, led a global campaign that drove up vaccination rates, drove down deaths from diarrheal diseases, the first World Summit on Child Health held in 1990. It was a remarkable period. But after Jim Grant's sad death in 1995, the world took its attention away from the fate of children. The advent of the Millennium Development Goals in 2000 should have been a golden moment for women's and children's health, MDGs 4 and MDGs 5. That was a moment for greater political attention, but not a bit of it. On the contrary, progress actually stalled at the beginning of the MDG era. And that's where Jennifer and her team of authors concentrated minds. It led to a certain degree of envy from other dimensions of global health. As soon as we published the Child Survival series, Joy Lawn came knocking on my door saying, "What about newborns?" So the Lancet had to do a series on neonatal survival. And then Una Campbell, Veronique Filippi, and Karine Ronsmans came and knocked on my door and said, what about maternal health? So we did a series on maternal health, quite rightly. And then we had those from the sexual reproductive health community coming and saying, what about family planning and associated issues? So we did that. So we had a series in the early 2000s of series. Not only did we have those series, but that then drove a complete conceptual reformulation of the field. Because at that time, these areas of child, newborn, maternal, sexual reproductive health were operating not just independently, but competitively, and damagingly so. And the reformulation, it seems so strange to think that this wasn't the case, but the invention of the concept of continuum of care in the mid-2000s changed the way we thought about the interrelationship of these different fields. That then led to a very fertile period of policy development that is important just to remember. The countdown to 2015, as it then was, now to 2030, which is led by TIS, of course, was a very powerful way to bring together data, equity, and policy, as well as financing, to focus minds in countries about what could be achieved for children and young people. The Partnership for Maternal, Newborn and Child Health was created to, in a sense, institutionalize this collaboration between sectors. We had engagement of heads of state. Jens Stoltenberg picked up the baton and was absolutely fantastic in leading other presidents and prime ministers in these areas. Although not everybody's cup of tea politically, without Stephen Harper investing in Muskoka, we would not have made the progress that we made again for a G7 country to take the baton of women's and children's health. And we owe Canada a great debt of thanks for their work. We had a United Nations Secretary General, second to none, Ban Ki-moon's Every Woman, Every Child initiative. And he had the confidence to make every woman, every child, and then every adolescent a central plank of his leadership because of the scientists who delivered the data to give him that confidence to make that political commitment. We had strengthening of accountability systems, and we had a massive scale up of investments. And then we got to 2015, and the MDG era ended, and the momentum just drained away. You could feel the energy going out of the field. Now, it would be very tempting to blame everybody else for that deflection of attention and concern. A new Secretary General, not as interested in the fate of women and children. New leadership at WHO and UNICEF, not as interested in picking up this initiative. Presidents and prime ministers, they'd moved on to other subjects. But honestly, I think that we need to look at ourselves in the academic and policy communities and scrutinize whether we could have done better, because we could have done better. We should take our fair share of responsibility for that deceleration of political attention, because we failed to rethink the place of children and young people in our vision for health and sustainable development. And that's what's been taking place over the last few years, rethinking what that place is. And this series, to me, is the apotheosis of that thinking. First, we had the WHO UNICEF Lancet Commission on Future for the World's Children, which tried to re-embed the future of children in a very different agenda, one of environmental degradation, conflict, migration, and commercial exploitation. We had the series on women's and children's health in conflict settings, a series on adolescent nutrition, And now what I really do believe is a landmark piece of work that links many of these things together in one unitary framework. Now, you're shortly going to hear the details of what that framework is, but I do want to draw attention to several disturbing similarities with where we were back in 2002, 2003, and why this moment is so important, not just scientifically, but politically. Back in 2002, we were very concerned about the issue of equity. Well, that issue of disparity hasn't gone away. In fact, as the pandemic, which is still continuing for anybody who thinks otherwise, disparities have only got worse. Disparities in determinants, in the availability of services, and certainly in outcomes. Second, back in 2002, we were very aware of gaps in data. There are still shocking gaps in data from low middle income settings. For those of us who've spent many years trying to draw attention to the importance of civil registration and vital statistics systems, unfortunately, this represents our continuing failure to get traction on the issue of health information systems. Third, a sense of complacency still affects, I'm sad to say, donors, global health initiatives, and even some corners of multilateral agencies, as if the job has been done. And partly we are responsible for selling the message that the job has been done by an over-focus on mortality. Yes, we reduced, collectively, the world reduced the numbers of under 5 deaths from over 10 million to just over 5 million over that 20-year period. But that's a horribly reductive way to think about the lives and future of children and young people. And it's the wrong way to think about it. And we need a much more capacious vision for those futures. Fourth, the continuing lack of investment in children and young people. We now need to build an investment case following this series. And lastly, a more philosophical point, and that is the insufficient attention we give to the place of children and young people in our idea, our sense of what it means to talk about a just society. So this series you're going to hear about this afternoon is a really important opportunity. It's an opportunity for, if I may say it modestly, a third revolution for the health of children and adolescents, listening to the needs from countries, promoting a renewed global attention, possibly for another World Summit for Children, the importance of partnership. What the series in 2003 triggered was an unprecedented partnership between multilaterals, financing instruments, civil society, the private sector, governments, and that's what we need to trigger today. And it's a great pleasure, it's wonderful to see Tedros in the video, and it's a great pleasure to introduce a new partner, a new person, Catherine Russell, the Executive Director of UNICEF from February of this year. She was previously in the United States government. She was an assistant to the president, and importantly, she was ambassador at large for global women's issues within the US State Department. So please give a very warm welcome to the image of Catherine Russell. Thank you.
Colleagues and partners, I'm so sorry I can't join you in person, but I'm on mission in the Horn of Africa, where the situation facing children grows worse by the day. But I did very much want to share a few thoughts. The launch of this Lancet series on optimizing child health and development comes at a pivotal time. The COVID-19 pandemic has had a tremendous impact on child health, rolling back hard-won progress across multiple indicators. It may be years before we can fully grasp the scope of the pandemic's impact. But we have to be honest with ourselves. Our progress was faltering even before the pandemic. In fact, the pandemic has flourished in places where weak primary health care and compounding deprivations were already undermining health outcomes for the most vulnerable mothers and children. Today, no country or region in the world is unaffected by inequity in the quality of health care, and thus inequality in health outcomes. As the evidence shared in this series substantiates, where a child is born, their gender, their race, their ethnicity, or their family's income status can mean the difference between living or dying, flourishing or being left behind. Consider child mortality. The burden of child deaths is uneven across regions. In 2020, more than half of all deaths of children under 5 occurred in sub-Saharan Africa, followed by Southern Asia with just over a quarter. And within countries, the most disadvantaged children, especially those in remote rural areas and urban slums, are at greatest risk. Children living in conflict-affected areas are particularly vulnerable. In 2020, the under 5 mortality rate in 38 conflict-affected countries was 3 times higher than in all other countries. New, escalating, and persistent humanitarian crises in Afghanistan and Ethiopia, Yemen, and now Ukraine are sober reminders of how much more we need to do. Colleagues, as the world continues to respond to and recover from the COVID-19 pandemic, we must use this momentum to advance health for every child. That means investing in the services and systems that children rely on. It means expanding access to robust, resilient primary health care and routine vaccination. It means taking a holistic, multi-system approach that serves the intersecting health needs of every child, wherever and whoever they are. And it means working together to secure sustained, adequate, long-term funding for child health. In closing, I want to look back for a moment. A decade ago, this June, nearly every government in the world came together in support of a promise renewed, committing to accelerate gains in child survival. The world rose to deliver on this promise. We formed new partnerships. We invested in innovations to reach the most vulnerable children. At UNICEF, we helped lead a greater focus on children at every stage of life through adolescence and on non-communicable diseases. So we know what solidarity looks like. We know what it can achieve, and we know what we need to do. There is hard work ahead. Gone are the days of seeking silver bullets or best buys. Each of us must come to the table ready to recharge a global movement for children's health. UNICEF stands committed to lead this effort with all our partners in health, nutrition, and all the sectors that help children survive and thrive. Let's use this momentum to build a fairer, healthier world for every child, everywhere.
So, ladies and gentlemen, to move you now closer to the meat of the thing, what is it that we are talking about? It's my great pleasure to invite Jocalyn Clark, my fellow Canadian colleague, academic, who's a senior public health scientist and executive editor at the Lancet. So I've followed Jocalyn's career over the years, PMJ plus ICDDRB, and she's been a major partner in much of our recent efforts, not only in this particular series, but also in the conflict and maternal child health series that we did and the maternal child undernutrition series. Jocalyn's on several advisory councils, including the In-Depth Network and Global Health 50/50 and Women Lift. And she will introduce the specific papers of the series and their authors and take you through the question and answer session. Jocalyn, the floor is yours.
Thank you, Zulfi, for those kind comments, and welcome everyone. It's absolutely wonderful to be here. For those of you in the room, it's lovely to see a group of people gathering again, and also everyone on the live stream. You're very welcome and delighted that you have joined us. I wasn't at the Lancet in 2003 when the Child Survival Series was launched, but it's absolutely brilliant to hear the stories and the history of that series. Because it has a kind of legendary status at the Lancet, as Richard mentioned, both because it galvanized such an important revolution, Jennifer, for action on child survival, but also I see it very much seeding the flourishing and very successful program of series and commissions at the Lancet on global health, which I have been very, very privileged to be a part of many of them. Some of which Richard mentioned as well. So it's really wonderful to be here with all of you. I feel like acknowledging the legacy and the history of this work is incredibly important for those of us who are a bit newer to the field, but also just a way for us to acknowledge all your incredible work. At the same time, I want to take the opportunity, since I'm here, to thank everybody behind the scenes who made this series possible. So I have been doing this long enough that I know for sure when something looks and reads as good as this, that it means an enormous amount of effort has been put into it. I know the authors of the series can attest to the amount of hard work we put them to, but there's very, very many people behind the scenes who have helped make this series so readable, and we hope to be so impactful. So some of them are in the room today, Richard, of course, and many others I want to thank, and of course want to thank all the series authors for persisting and managing to produce such a beautiful series of work during a very, very difficult time. So that's why we're here today. We are going to take an in-depth look at each of the series papers. I'll introduce each of the lead authors in turn, and then at the end of at the end of the 5 presentations, I'll take some questions, both from the audience and from our online audience, and then we'll move into a moderated panel discussion. So for those of you online, please do start sending your questions. We will log them and vet them. And for those in the audience, I'll come back to you in a few minutes. So without further ado, I will introduce our paper 1 lead author, and that's Professor Bob Black from Johns Hopkins. Bob.
Thank you, Jocalyn. I start with this because I want to acknowledge the many contributions of the co-authors of this paper, many of whom worked in very specific aspects across the life course or had particular expertise that we drew upon, and it's a it's very much a joint effort of all of these co-authors. So, as you know from the title, Optimizing Health and Development and Human Capital, we did want to focus on many aspects that contribute to human capital. The World Bank defines human capital, or has an index that includes child and adult mortality, child height, under 5s, and education. In our view, a rather limited list of possible indicators of the contributors of human capital, but this is used as a measure of national investment in the capabilities and economic potential of the citizens of countries. Our broadened concept of human capital includes health, nutrition, other aspects of well-being, knowledge and interpersonal skills to fulfill individual and societal potential. So in this paper, we consider the life course determinants of human capital before adulthood and include loss of life and nutrition, both before birth and for all children and adolescents up to the 20th birthday, along with disabilities and, of course, education. We also present in the paper the regional disparities in some of the important determinants of human capital, and we provide some new analyses of the effect of growth across the life course in regard to adult capabilities and health outcomes. The nurturing care framework was initially developed to inform policies that would ensure that young children reach their developmental potential. It was adapted for the series and published prior to the series itself to include the determinants of human capital, beginning with preparing for conception and continuing through the provision of healthcare, good nutrition, and learning opportunities throughout childhood and adolescence. Nurturing care can mitigate the consequences of early child adversities, and is particularly important during the early period of childhood and also in adolescence. Of course, we did want to deal with mortality, and in this case, as you see in the top line, our global measure of mortality across this part of the life course has declined about 45% from 2000 to 2019. Now, in this, our measure of mortality, we include the stillbirths as well as all of the deaths through childhood and adolescence. The mortality rate in the 1 to 59 month age group, that's the second line down in orange, has had the fastest decline, as I'm sure you know from looking at mortality statistics. And the next line below that is the neonatal mortality, which also has a reasonable slope down. The other age-specific rates below that have flatter slopes, and as you get down toward the bottom of this figure, these lines are virtually flat. These rates of mortality are also rather low at that point for the older children and adolescents. Overall, if you include the stillbirths, half of the almost 9 million deaths are before 1 month of age in this group, and 83% are below 5 years of age. Of course, we wanted to look at the regional survival disparities, and as you can see in this, they are quite large. West and Central Africa has the highest rates of mortality with this measure, but the east and southern areas of Africa and South Asia also continue to have high mortality. So I said overall, stillbirths and neonatal deaths represent half of the deaths in this spectrum of mortality. But one difference is in South Asia, the stillbirths and neonatal deaths are about 2/3. And this is related to the fetal malnutrition and low birth weight that's particularly a problem in that region of the world. We used survey data to analyze the regional differences in length or height and body mass index from birth to 19 years of age, and looked at this by world region and in comparison to international growth standards. With the figure in the top left, which is, and I'm showing this only for girls for the sake of time. We did it for boys, of course, as well. The figure at the top left is for the change in length by region from birth to 5 years of age. As you can see in the figure, the starting point at birth length is very, very similar for all regions of the world. And yet over the 5 years, that length curve deviates so that at 5 years, there is a gap up to 10 centimeters. The top line there is the international growth reference. The bottom line is South Asia, but there is a 10 centimeter gap or faltering in growth at that point. To the right, the top right, is the change in height from 5 years to 19 years, using different survey data, and they don't exactly match, but almost entirely the relative position of the lines is the same. And as you see in the top right, the growth curves are basically parallel from 5 years up to 19 years. And they reflect the starting point at 5 years of what the height was of a child at that time. The figure on the bottom left is a little different. This is for BMI. And with BMI at birth, you see more difference by region. And this is because there is, in some regions, more growth faltering in the fetus, fetal growth restriction. and a greater rate of low birth weight. So the lower weight at birth leads to a lower BMI, so particularly for South Asia. So there is a difference in the starting point, and then there is a change of BMI, as you would expect, goes up and then flattens out. After that, in the 5 to 19 years, the lines again are rather parallel. There's a little switching around in the latter part in adolescence, but for the most part, they do parallel and reflect the starting point at 5 years. Of course, though, in some regions of the world, particularly high-income countries and Latin America and North Africa and the Middle East, these curves go above the WHO growth reference, indicating increased adiposity in adolescence at that point. School enrollment has increased, fortunately, from 2000 to the present, but school enrollment per se is not an ideal measure of the contribution to human capital. It's not itself a good measure of learning. So learning adjusted years of school, or LAYS, use performance on international standardized tests to adjust the country's grade attainment. And so analysis by these learning adjusted years of school indicates a huge disparity for education and for learning. So analysis shows that for the high income countries, LAYS are about 11. For the African countries on the far left, West and Central Africa, and also pretty much the same for East and Southern Africa, it's only 4. So a huge disparity in the education of children. We analyzed data from the Cohorts Consortium that includes population-based birth cohorts with at least 20 years of follow-up. And these are data from Brazil, Guatemala, India, the Philippines, and South Africa. I'm just showing a sample of results here, but in this sample, we're going to look at how changes in growth affect IQ and schooling, as well as overweight or obesity and metabolic syndrome. So length at birth, and this is the figure on the right. So length at birth does affect the adult IQ. So the first dot with the whiskers is length at birth. The second one to the right is gain in length between birth and 2 years of age and up to early childhood. And that is the strongest predictor of adult IQ. After that, changes in height from that point to middle childhood or from middle childhood to adulthood has no effect, no predictive effect on IQ. You see a rather similar picture with attained schooling as well. So the next ones look at the relationship of weight to the adult outcomes of overweight or obesity and metabolic syndrome. As you see on the panel in the left, the weight at birth has a small predictive power for being overweight or obese as an adult, and that continues throughout childhood. But there's a much larger effect of conditional weight gain that's controlled for prior weight and for height for adolescence. And you also see the same pattern for metabolic syndrome. That is, the weight throughout childhood does have a small predictive effect, but it's very particularly the excess weight gain in the adolescent period that has a very detrimental effect in predicting the conditions that are components of metabolic syndrome. So in conclusion, I would say that human capital depends on survival, of course, throughout the life course. It requires a foundation of health, nutrition, knowledge, skills acquired during that period before adulthood. And we believe that the measures of human capital should be expanded to include stillbirths and deaths through childhood and adolescence, disability, which I haven't shown you, but it's in the paper, height and weight at birth, and other indicators of learning, safety, security, and relationships as conceptualized in the nurturing care framework. I've shown you regional disparities that are enormously large in mortality, in growth, in haven't shown, but they're there, in disabilities and in education. And children in the sub-Saharan African countries and in South Asia have the worst chance to survive and thrive and build human capital. Thank you.
Thank you, Bob. That was terrific and breezy summary of a very dense and foundational paper for the series. So our paper 2 series lead author is next up, and this is Professor Cesar Victora from the Federal University of Pelotas in Brazil. So welcome, Cesar.
Thank you, Jocalyn, and good afternoon, good morning, good evening. In the first Lancet series, I led a paper on the first Lancet Child Survival series. I led a paper on inequalities, within country inequalities in health, which was a bit of a novelty at that stage, because there was this wrong idea that within a low-income or a middle-income country, that every child was poor and every child was equally affected by a number of detrimental influences in their health and development. And we showed in that there was a standalone paper on equity, which is not the rule for Lancet series, right, Richard? And therefore, 20 years later, we're here with yet another paper on equity, but now we have much more data. The data gaps are much smaller now than they used to be. And I looked not only at the short-term consequences of poverty in childhood, but also at the long-term, using data from cohorts. So my first part of my presentation is on how exposure to poverty in early life affects child and adolescent health and nutrition development. And I use surveys from low and middle income countries from 95 different countries. And the second half of my presentation is on the long-term consequences of early poverty by looking at the longitudinal birth cohort studies that Bob just mentioned, the cohorts collaboration. We have, for adolescents, I'm focusing on 5 outcomes for children and adolescents: survival, linear growth, child development, achieved schooling, and teenage parenthood. These are based on the data we have. We would certainly like to have more indicators, but this is what we have, and they show a very compelling picture. This kind of graph is called an equiplot. We came up with this graph to try to present within country inequalities in a simple way. And the traditional approach is to use wealth quintiles based on household asset indices. We can actually use deciles. Deciles give us a finer discrimination granularity in presenting how different these kids are from other children in the same country. So basically, we had 95 countries. We pulled each region of the world using data from the countries weighted by the number of under 5 children in each country, and this is what we get. You see very wide gaps. The red dots are the richest decile. This graph here is on under 5 mortality. The dark blue circles are the poorest deciles, and for most of these, we found what we call the social gradient in health. You know, the poorer you are, the worse off you are. It's not just a matter of a dichotomous difference between rich and poor. It's really gradual. It is a gradient that affects all children in a society. You see that the widest gaps are for West and Central Africa and South Asia and East and Southern Africa. We have narrower gaps in other parts of the world, but they're all there. There's a lot of information in this slide, of course, so please read the paper where the graphs are in proper size. But we found the same thing for everything else we studied. We found the same thing for stunting prevalence on the top. We found it for not being on track for early child development based on the ECDI scales. Very huge gaps. Teenage motherhood, another negative indicator of human capital, having a kid while you're still a girl. Also incomplete primary schooling. If you look at schooling, you see that some parts of the world, like Eastern Europe and Central Asia, at the very bottom, is the one where we hardly have any inequalities because everybody completes secondary school, primary school. But in other parts of the world, the gaps are incredible. Look at the Western Central Africa, well, 5% of kids in the poorest decile complete primary school, even primary school. I mean, 5% in the richest decile do not complete primary school, and about half the kids in the poorest decile do not complete primary school. 1 in 2 children don't even go past primary education. Now, the summary of this part 1 is that there's highly consistent associations between poverty and all these outcomes. The widest gaps are in Sub-Saharan Africa and South Asia, exactly the regions where Bob showed that we have the poorest, the worst indicators of human capital and child development and nutrition. In the narrowest gaps in Eastern Europe and Central Asia. So far, we don't know what's going to happen in this region with the recent crisis. Now, the second part is based on the Cohorts Consortium. This consortium was put together for the Lancet 2008 Nutrition Series, Maternal and Child Undernutrition Series. And I was always, I've been running birth cohorts since 1982 in Brazil. And I was always concerned that if you draw a world map with the size of the countries proportionate to the number of birth cohorts they have, this is a map we get. We have very few birth cohorts, long-term birth cohorts from the South. And at that stage, I managed to get together with the PIs of all these studies, and they all accepted immediately to join what became our consortium, which is we baptize as cohorts. The data we have from these cohorts, they reflect not only human capital, but also adult health outcomes. And I'm going to go through them quickly in the next couple of slides. If we look at human capital, in the 3 indicators we have is attained height. I mean, if you're not shorter than you're genetically programmed to be, and also include IQ and schooling. And this, I'm using quintiles here because sample sizes are not large enough to divide the population to 10 groups, so I divide it into 5. And what we find here is in the reverse position that we had before. The richest are much better than the poor. These are positive outcomes. So you get this equiplot, which is flipped around relative to the ones that reflect the poor outcomes in the first part of my talk. You see huge differences in schooling in most regions, in most cohorts. They're separated for men and women, but you see huge gaps in IQ. I was really impressed. These are my 2 birth cohorts in Pelotas are sort of halfway in the lower half of this graph. We have up a 20 IQ point difference in adulthood for children who were exposed to poverty in their early life. This is a lifelong intergenerational effect that will definitely affect their future earnings and their future position in society. So what we found is that early life poverty is very clearly associated with the human capital outcomes and schooling height and IQ. But we have variable results for adult health and nutrition. In some cases, it was worse off to be a rich kid than a poor kid, for example, for overweight and for metabolic signs in men, but not in women. Yeah, we have this paradox. It's a rich men who are overweight and have more metabolic signs, and the poor women. And that varies according to the position of a country or cohort in the nutrition transition. As the transition moves, it shifts around, and it shifts first in women and then in men. Placing the finding in a global context, I won't spend time here because everybody's talking about COVID, but my point here is that I'm not looking at the effect of COVID on health. I'm looking at the effect of COVID on wealth, on poverty. And we were doing pretty well until just before the pandemic. The number of poor families was reduced globally, except for Sub-Saharan Africa, where which is the blue part of the graph at the bottom. But the absolute numbers of poor individuals in a society was really going down. But then COVID struck, and it's not only the health effects that worry me so much, but also the effects on schooling, on development, and on family income that will definitely affect the next generation. Now, the key messages are that both the survey and birth cohort analysis confirm the importance of early poverty, not only for children and adolescents, but also for adults. It's a lifelong effect. And because today's children will be tomorrow's adults, the present inequalities that we're seeing now are likely to affect health and human capital in the next generations and for several decades. The third point is that biomedical and education interventions are really important, and we've been stressing that since the 2003 series, but they need to be complemented by a broad anti-poverty and multi-sectoral agendas. And finally, that action is just even more urgent now in the face of the effects of the pandemic. Thank you very much.
Thank you, Cesar, and to both you and Bob. There's a lot of material to cover in 7 minutes. We really appreciate you rising to that challenge, and also indeed to have you, because you were part of that original series 20 years ago, continuing your good work and in partnership with the Lancet. So we're going to move for our next presentation from the kind of old guard of the child survival scholarship to the next generation, let's call him. I didn't check, but I'm pretty sure our next presenter wasn't an author on the 2003 Child Survival Series. In fact, he may have been the subject of the child health research back then. Tyler Vaivada from SickKids in Toronto to tell us about paper 3.
Thanks so much, Jocalyn. It's a privilege to be here today. And I'm going to share with you today some highlights on behalf of the large team that contributed to paper 3 in this series, which is an overview of evidence-based interventions and delivery strategies to support child health and development from preconception to 20 years of age. So despite improvements in recent decades, the coverage of life-saving interventions remains inadequate and inequitable. So there are wide disparities across income groups and geographies, and high rates of child mortality, morbidity, and suboptimal development disproportionately impacts children in low and middle income countries and low resource settings. Children that are exposed to poverty, malnutrition, and illness and other adversities experience negative outcomes from birth and throughout childhood, and the consequences of which can persist into adulthood. And while a variety of health issues, biological risk factors, and social and environmental determinants of health can compromise child health, there is ample opportunity for intervention at every stage of the life course, from before conception through adolescence. The key domains of child health that we targeted were adapted from the DCP3, with a special focus on targeting the most vulnerable children. So interventions addressing maternal newborn health, nutrition, and infectious diseases have been widely studied and promoted as some of the most effective ways to reduce under 5 child mortality worldwide. To address gaps in existing evidence syntheses, we also decided to specifically focus on collating the evidence for interventions for school-age children and adolescents. Starting with the preconception and pregnancy period, we highlight the effects of several interventions that can help address the major causes of morbidity and mortality during this period, which include stillbirths, neonatal mortality, preterm and small for gestational age, and congenital anomalies. The main themes here revolve around high-quality antenatal care, which includes support for maternal infection prevention and treatment, preconceptional and antenatal nutritional supplementation, and prompt detection and care for pregnancy complications. For the period involving labor, childbirth, and newborn care, there is evidence supporting a wide array of interventions that can address mortality, infections, and birth asphyxia. Routine interventions for all newborns involve hygienic cord care, skin-to-skin contact, and early and exclusive breastfeeding conditioning. However, the greatest impacts we see on neonatal mortality and infection are in those interventions targeting the most vulnerable, so preterms, low birth weight, and ill newborns. For infants and young children under 5, interventions to prevent mortality and infections remain important, And this includes supporting optimal nutrition with supplements for those children at risk for undernutrition and micronutrient deficiencies, as well as infection prevention and treatment measures. Other interventions in support of nurturing care, such as for parenting and early learning, and for the prevention of child maltreatment, are also required to optimize child development. So in general, there are a variety of effective interventions, evidence-based interventions available for young children, though further scale up and linkage to school age is still required. We know that a good start to life is essential. So interventions must be delivered early to have maximum benefit, and a multi-sectoral approach to nurturing care needs to continue into later childhood and adolescence to support and maintain these benefits. So as children continue to grow, develop, and enter the school system, they experience the transitionary period between early childhood and adolescence. Autonomy and independence increase as children begin to form closer peer relationships, spend more time away from their families, and develop lifestyle habits that are influenced by their social and physical environments. Although rates of mortality are lower compared with children under 5, infectious diseases and nutritional deficiencies they associated with poverty, they continue to be important causes of death and disability in school-age children in LMICs. Non-communicable diseases and injuries also become important emerging causes of death and disabilities for this age group. And although evidence from appropriate randomized trials is still sparse, school-based and digital platforms present additional opportunities for the delivery of interventions to school-age children. So in order to help fill gaps in evidence syntheses and on interventions in school-age children, our team of collaborators developed 9 new systematic reviews. The specific topics chosen were related to the major causes of morbidity and mortality in this age group, with an additional focus on emerging interventions and delivery platforms, and on targeting the most vulnerable and marginalized. With the exception of interventions for high-burden infections and neglected tropical diseases, the number of studies and reviews containing evidence from high-income settings far outnumbered those from LMIC settings across the board. In terms of infectious diseases, various types of vaccination promotion interventions were effective in improving vaccination coverage, including education, provider-based, school-based, and policy interventions. The importance of water treatment was also highlighted, and both mass drug administration and health education were effective at addressing different neglected tropical diseases. We found evidence for several interventions targeting NCDs in school-age children, including rheumatic heart disease prevention and sickle cell disease management. And interventions to support nutrition and a healthy active lifestyle include micronutrient supplementation and fortification. We also identified some digital-based interventions that showed promise for improving the intake of fruits and vegetables, as well as interventions to reduce sedentary behavior. The importance of mental health, injury prevention, and the promotion of sexual and reproductive health increase in school age. And educational interventions to prevent drowning and road traffic injuries can effectively increase knowledge, but there's little data on the mortality impacts of these interventions. Education on various aspects of sexual and reproductive health will also show promise for increasing both knowledge and contraceptive use. We also identified a variety of promising interventions to support mental health and positive development in children. The impacts of the COVID-19 pandemic and associated restrictions and school closures have highlighted that there is considerable mental health needs for school-age children. And both health systems and schools must address these needs if we are to rebuild equitable and resilient services post-pandemic. We identified multiple reviews that suggest interventions to promote mental health in young people can be implemented effectively in LMIC school and community settings. There is promising evidence for the beneficial effect also of positive youth development programs. However, there is a general lack of experimental evidence for school-age mental health interventions in the LMIC context, especially considering the substantial burden of disease that exists there. When also considering evidence from higher income settings, there's evidence supporting the beneficial effects of universally delivered preventive interventions on children's mental health outcomes. In summary, evidence from high-quality randomized trials on the impact of school-age interventions in LMICs is sparse for many domains of child health. Despite this, some effective school-age interventions do exist. The research from high-income settings would need to be adapted and trialed in different low-resource contexts. Lastly, as a complement to robust health systems, a variety of other delivery platforms and strategies can be used to reach vulnerable populations in greatest need. A special thanks to our SickKids team, our external partners, and our funders for contributing to this work.
Thank you, Tyler. That was a terrific presentation. And on to paper 4, which will be described by the lead author, Professor Margaret Kruk from the Harvard School of Public Health.
Thank you very much, Jocalyn, and wonderful to see colleagues here in person. And just to express how wonderful it is to be involved in this historic trajectory of efforts on child health. So with no further ado, I want to introduce our co-authors, and a particular shout out and recognition to Todd Lewis and Catherine Arsenault back in Boston, who were instrumental in the analysis, the original analyses and literature reviews in this paper, as well as our colleagues from 7 other countries. And next, please. Oh, I have control, yes. Wonderful. Okay. So what is this paper for about, and where does it fit with these series? I think you've heard about the problem statements in the previous papers, particularly that despite success, we have remaining with us many gaps between rich and poor kids, between rich and poor countries, between boys and girls, and I would say even along the life course of children, we see children with heavy and substantial interactions with the health system and others who have almost no contact with the health system. And so what we did in this paper is try to understand why is it that despite the progress made and despite the increased coverage of interventions and the knowledge of what works, we're still failing to achieve parity in health outcomes and in developmental outcomes that we all would want. And I think we begin with a hypothesis in this paper that increasingly mortality and morbidity are a result of system failures. These are not failures of knowledge, not failures of a parent or a single country or a single community, but rather system failures that include poor governance, low quality services, and critically, the lack of any connection between the health system and other social systems. So the conceptualization of this paper really rests on understanding the performance of health systems, as well as what we call adjacent social systems that should be serving children better. So what do we mean by a high quality health system? It's a health system that is fundamentally for and about people, including for and about children, and that consistently delivers services to improve health, build trust, and adapt to changing population needs. And here is the problem. Many health systems do not adapt. They're well organized to serve the under 5s, but much less well organized to serve older children and adolescents. But health systems are not sufficient. The problem or the challenges are too large, and so we need adjacent social systems. What do we mean? Well, they begin with empowered families, families who know what to demand from health and other systems, who know what to do for their kids. We need caring communities surrounding those families because it does take a village. We need capable schools. And then with some caution and care, we need to be able to leverage new platforms as well. Let me get into the findings. So first of all, around pregnancy and newborns, and we, like the other papers, took a life course approach in understanding the performance of systems for kids. Starting with pregnancy and newborns, as you are all well aware, most newborn deaths are in 2 regions of the world, the vast majority. And this is where I think our focus really needs to be. What's the cause? Well, certainly it is in part, particularly newborn mortality and early newborn mortality, dramatically influenced by lack of rapid care for obstetric and newborn emergencies. It isn't sufficient to deliver in a health facility that cannot take care of the mom or the baby when a problem develops. It's just not adequate. And yet the world has been resting on its laurels in getting lots and lots of women to deliver there over the decades. What we see further is if a child is born and develops an illness, what the systems do is very little for that child. We see from the work of colleagues in Kenya, for example, that among sick babies who made it back to hospital, only 40% received minimally adequate care to look after their condition. So insufficient provider knowledge and effort are behind this, poor monitoring and treatment errors, and crowded facilities and weak management. What you see on the right is that coverage, which is the light bar, is often higher Then quality, and this is just one metric of quality. It's not even my favorite, but data here are very, very scarce. So this is looking at postnatal checkup of any kind before discharge that those babies received. Surely we should care before that baby goes home within 24 hours as to how they're doing, whether they have a fever. Moving on to childhood and adolescence. We know that 50 million children globally have a developmental disability due to birth asphyxia, malnutrition, lack of nurturing care. And as you've heard over and over throughout this presentation, the first 1,000 days are absolutely vital for intervention. Infectious diseases. While we have made massive gains in immunization, by the way, gains which are deeply threatened by the COVID pandemic, where we and others have shown huge declines in immunization rates, and in some countries just beginning to rebound. We also see poor treatment for common conditions, extremely common conditions. Many kids with pneumonia don't get antibiotics, and those without pneumonia get antibiotics. Similarly, for diarrhea, we only see about 40% of kids getting the proper oral rehydration therapy. Furthermore, if a child gets really sick, there's a failure of connectiveness in the system in terms of follow-up and referral. And so people go home, and we've seen from careful ethnographic studies, particularly in several countries in sub-Saharan Africa, there are multiple system failures that accumulate to cause a child death. Let's turn to injury. There is, first of all, a higher prevalence of injuries and higher death rates from injuries in many low-income countries due to broader social systems and social sectors, road safety, car safety, etc. Mortality, for example, from traumatic brain injury is 4 times higher, even conditional on the higher prevalence, than that in high-income countries. Mental health conditions are extremely common, all the more so during the pandemic, especially in adolescence. But where do those kids go to get care? Where would they call and where would they turn to? It's not clear for many of them, and so many of them don't get care. Cancer is a particularly an area of particularly egregious discrepancies, where we see 80% 5-year survival from childhood cancers in high-income countries versus 30% or lower from treatable cancers in low-income countries. So this is how we look at health system quality writ large. They are failing our children. Turning to adolescent reproductive health care, we've already heard about the high rates of teenage motherhood and how unevenly that is distributed across social gradients. So that is something that is a deep concern, and obviously a societal issue, not just a healthcare issue. But what we also know is that family planning is inadequate in many settings. Fewer than 50% of young women, adolescents who do reach out to the health system for family planning report any counseling at all about what that family planning method is. Adolescent boys are completely forgotten. They're excluded from healthcare in this area. And we see poor quality of reproductive services, poor technical quality, and higher rates of abusive and disrespectful care for adolescents. Just a small point. This is a very dense graph, and like others, I invite you to read the paper. The third column here talks about the proportion of adolescents who deliver in hospital versus other lower quality settings or home. And it should be 100%. Adolescents are at increased risk of complications, and their babies are as well. And yet we see inadequate care during delivery. Let's turn to another dimension of quality, which is user experience. 1 in 3 caregivers report problems with respect and customer service inside healthcare facilities. And let's remember that after age of 5, many children have very, very scarce contact with the health system altogether. And adolescents in particular are much less likely than adults to have a regular source of care. This chart here shows adolescents compared to older individuals. So adolescents are in the dark bars. And if you look all the way to the right, you can see that in high-income countries, adolescents, about 90% can say, yeah, I have a usual source of care. I know where to go if I got sick or if I need family planning or something else. That's still lower than adults, 94% of adults. But look across the other regions of the world, where we see 50, 40, 56% of adolescents having any notion of a regular source of care. And this is really important. Here we are talking about universal health coverage. We're talking about the importance of primary health care, but half the world's adolescents are unconnected to the health system. And so another question that we can ask, which to me is a very useful summative question of the user's perception of the quality of healthcare, is to ask, if you got sick tomorrow, would you be able to get the healthcare you need? Because surely of all the functions the healthcare system has, this rescue function is a key one. And again, high-income countries are the red bar on the left for comparison. And you can see across a number of countries, and these data are also scarce, and these data have been carefully compiled through multiple countries and over multiple years. So please take them with a little bit of a grain of salt. But you can see much lower rates of confidence in the ability to get care from the health system across low and middle income countries. So how do we address this? How do we begin to cover the gaps between our intentions and the reality for kids on the ground? Well, one thing we do know from the literature is that local action, telling providers what to do, telling moms to do better, maybe telling communities to step up is not going to be enough. Those local behavioral short-term types of efforts that we're very committed to and very familiar with rarely lead to elevating the system as a whole, and it is that fundamental change that is going to be needed to close the gaps we've just been describing. So we are asking for structural or macro level system changes. Let's start with politics. I heard a little bit of reference to politics today. Our paper makes more reference to politics. It does start there with a decision to prioritize the continuum of care for children, to make it a political priority with jobs on the line, reputations on the line, money on the line. So system level reforms are what we're calling for, that are longer term and larger scale. And unfortunately, large scale and long term are not usually compatible with political priorities of many of the folks making decisions. What are these structural changes we focus on in this paper? There are three. One is governing for quality. The second is redesigning service delivery. And the third is empowering families. So let me just say a brief word about each of those. Governing for quality. We're not asking for QI cycles. We're not asking for PDSA cycles, again, or behavioral exhortations. We are asking for rethinking of how healthcare systems and other social systems are led, managed, and coordinated. We need clear goals and a clear understanding of what is performance in the system from the top all the way down. We need an update of policies. Who should be looking after children in the country? How many pediatricians do we need? How many adolescent health specialists do we need? Mental health specialists? Are we training our primary care docs and nurses with the mental health counseling skills, for example, that are so essential? We need much more, many more trained managers, not doctors managing clinics, not that good. We need trained managers managing clinics. We need greater program coherence and unified oversight. And here, I want to say that having multiple donors calling the shots in countries has been incredibly destructive and disruptive in many settings, as has been made clear to us by our co-authors and experience. Learning systems. So health systems should be learning and adapting as they go, which starts with vital registration. So we know who the patients are, who are the users, who is alive and who has died. So I want to really echo Richard's earlier call for reinvestment in vital registrations. We have no denominators. So it's difficult to be accountable when you don't have those data. Furthermore, clinical registries have been extremely effective in elevating the levels of care in many countries. Audits, mortality reviews, these sorts of efforts help systems look at their performance and do better. Again, not a clinic at a time, but a system, an entire system looking at its data. Patient level data are crucial. I haven't heard this said yet, but in many countries, you cannot get patient level data on health interactions. So there are no electronic medical records or really any records that are at the patient level. Most data from DHIS systems in low-income countries are aggregate data only. And so it is impossible for us to follow the course of care for a child. Service delivery redesign is about putting quality services when and where children need them and not where it is convenient for the provider only. So starting with birth care, we do think all children should be born in high quality facilities with immediate recourse to treatment should a complication arise. And that does not mean at home, and it does not mean in the local primary care clinic with a single nurse. We also need to shift some of the services for young children, particularly school-age children, away from the home to other settings where kids are going to be more often, such as schools. And in particular, whole school approaches to health are another possible opportunity in which health is really integrated into the curriculum as a whole, in addition to having school-based health services for those kids who need an immunization booster or family planning advice. Community outreach for mental health and child development. There's good data showing that trained community health workers, and let me just emphasize, paid, trained, supervised, and recognized community health workers, not women being asked to do this on the side, are really an important arm of the health system that can help, particularly with mental health and development. And then phones for health. As a mother of teenagers, I am slightly ambivalent about this last point here, but there are data showing that carefully used phone messages, reminders, can in fact promote positive health behaviors, adherence, support. Lots and lots of research to be done in this area, particularly in low-income countries. Most of the data is from high-income settings. And lastly, empowering families to know more about what their children need and to ask more from the system. So building parental capacities in the first years of life. Maureen is here with us, who's an expert in this. We know that parents' involvement and engagement only comes from understanding what their children need. And the nurturing care framework really shows us the full spectrum of what children need, including health, nutrition, responsive caregiving. And here again, we need more than the health system, right? We need the early childhood education system. We need communities and families to work together. Secondly, promoting self-management. Let's remember, a number of our kids are going to have chronic conditions, asthma or mental health challenges, diabetes, HIV. And so how do we get the kids, as they get older, to start to manage their own conditions and empower them to be the caregiver, at least for the routine aspects of care? And then raising expectations. So here's the problem. When we ask parents, how did it go? How did this visit go? What did you think of this health clinic? We often get stellar ratings that are far really disproportionate to observed quality of care in those settings. And we think some of that, of course, is courtesy bias and people being nice. And some of that is very low expectations that are honed over many interactions with inadequate health systems. And so raising expectations is one tool we have to have people be more demanding users of the health system. And we think that informing people about what they should be getting in care, like South Africa has taught us through the Mom Connect program, for example, are really important opportunities. But here, there's a lot of work to be done to understand how to do this best. Thank you very much.
Amazing, Margaret. Thank you. So those are the kind of the meat of the series, those 4 papers, and you've done such an outstanding job, all of you, to give the audience a taster of what those papers include. But in their full form, we invite you to take a look. For those in the room, you've got hard copies of the booklet, but there's many, many more people joining us online, and I don't think we've mentioned that you can go to Lancet.com and see the entire series freely available, along with 2 commentaries, one by the authors, which we'll have a summary of in just a moment, and one by Dr. Tedros and Dr. Russell, who we heard from earlier today. So thank you very much for that taster. And now I can introduce our final series author to talk about the way forward, and that is Professor Maureen Black from RTI International and the University of Maryland. So welcome, Maureen.
Thank you, Jocalyn, and thank you all for attending and for listening. I'm absolutely delighted to talk about the way forward. As you've heard, the series focuses on a life course perspective to human development, focusing on healthy growth and learning that starts prior to conception, continues through childhood, adolescence, into adulthood, and then on to the next generation. There's a continuous process here. But what happens early on is that it's certainly possible to go off course, and that there are threats then throughout development. When these happen early in life, then the disparities start, and the disparities then can continue throughout childhood, adolescence, adulthood, and then on into the next generation. So, of course, what we try to do is to prevent these or to alleviate the disparities throughout life. Now, what has happened, as you have heard, is that this whole process has been incredibly disrupted by COVID. And COVID has had an impact, very negative impact, on multiple aspects of children's health and development, including learning, including social development, whether you're a 3-year-old interacting with only who's at home rather than your peers, or a 15-year-old interacting with peers When children don't have this opportunity, it's an enormous loss. It can impact their health and their mental health. So that there are estimates from international organizations of the enormous loss that is facing our children and really all of us in lifetime earnings and lifetime development if we don't do something about this moving forward. So my task is to talk about the way forward. And one of the primary ways forward is to have a global summit on child and adolescent development. This would bring together some of the thoughts and plans, not only from this series, but what we've learned over the past 30 years, and to move to think of where we have been and then how we can move forward in this step. So there are 8 steps, 8 lessons to promote human capital for us to think about as we're planning this summit. The first, as we've said, is that there's a life course perspective. So rather than thinking about age-based silos, to remember that what happens in early life then forms a basis for what can happen throughout life. But it's continuous. There are no magic bullets here that will protect children forever, that there are steps along the way that children need as they grow and develop. You heard about the interventions and some of the amazing interventions that we have, and they vary by age. As children grow, there are threats all along the way. So there are interventions, and many of them work. But part of the problem is that they're not implemented well. They're not organized well. So we need some implementation and organization to ensure that what we have learned from the trials and the interventions can in fact be implemented. Then you have heard also some about the implementation involves not only the implementers, but it involves stakeholders, it involves policymakers, it involves participants. There's a whole science of implementation science, which is different from discovery science. We need to put implementation science in the forefront to learn about it because it's a system. And what it enables us to do is to use data, to use monitoring, to use accountability, to learn what works, and then to adapt systems so they are in fact effective and can work with our children and adolescents. And then children need multi-sector support. There's a phenomenal amount that they get from the health system. That's wonderful. That is necessary. That is not sufficient. Children also need from the educational system. Part of the issue is the collaboration, the coordination between education and health doesn't serve children so well. So we need better collaboration across systems, including health, education, and social services. There is not one pathway for children. There are many aspects that children and adolescents need in order to develop. Our task is to have the services sort out how to collaborate across them for our children and adolescents. Then we need enabling environments. Children need responsive, caring homes and families. Every child needs that, but homes and families need the support from communities, from services, from policies. Children need interactions with communities and services. We've learned that from the pandemic. It's not enough for children to be at home on Zoom. It just doesn't work. So we need these enabling environments that are bidirectional, that communicate with one another, and that serve children well. We need, the next one we'll talk about are country managed systems. So the countries need to have national goals because what works for one country does not necessarily work for another country. Countries need to be able to have their own country level management, country level accountability, Because after all, then there will be country level sustainability. So we need more within country management. We need a global summit to put things together, but we need country level implementation and goals and management. Then there's the global funding. Oh yes, we need global funding to enable this to happen. And this has been absolutely, the gaps have been widened by the pandemic. So what should we invest in from a global perspective? This is not a surprise. We should be investing in nurturing care, in the systems that make that work, and of course, in our children and families. And then equity. The eighth lesson that we have learned, and we need to keep learning and learning and learning, is one of equity. So we have an obligation to all children. As you see from the triangle on the left, the bottom includes all children. All children need nurturing care. And then above that, we have children who are in at-risk conditions. This may be children who have been undernourished. This may be children in conflict situations. And above that, at the top of the triangle, we have children who have additional needs. This would be children with disabilities, for example. If we look at the inverted triangle, then this refers to the intensity of intervention. So at the bottom, it's a relatively low level intensity of intervention that we need for all children. That could come from national policies, for example. As you move up, then you have increased attention for the targeted support, and that may be for children in conflict situations. And at the very top, you have indicated or specialized support, and those are for children with added needs. So this illustrates how we manage population coverage and intervention intensity in order to promote equity as we move forward. So what the Global Summit will do, will put us, hopefully, in place to move forward with the Sustainable Development Goals. 2030 is around the corner. What do we do? What can we do to reach that? Well, in the center of the diagram of the Sustainable Development Goals, what do we have? We have nurturing care, folks. We have children. And if we want to reach those goals and move forward, we need to invest in our children from preconception through adolescence. Thank you very much.
Thank you, Maureen. That was fabulous. So we are just being mindful of time, going to move on straight into our panel discussion. So for those who have questions for the series authors, please can I ask that you direct to them those questions to them directly. We'll take advantage of the fact that we have with us today. Can I please ask to come to the stage Dr. Jennifer Bryce, Dr. Boerma from the University of Manitoba and the Countdown Group, and Dr. Richard Horton, the editor-in-chief of the Lancet. Yeah, sit anywhere, get comfortable. I'll sit at the end.
Stood. Up first.
Yeah.
I'd be quicker than stood.
Would you prefer to stand? That's absolutely fine. So we hope to have a panel discussion. I think we'll spend the time, I think at the beginning, having a little look back, because this 2003 series was so foundational, and Jennifer, Bryce, you were such a fundamental and critical part of that. And so I know you prepared some remarks. We'd love to hear your stories from back then, and then that'll give us a platform for the next few minutes to talk about future forward. Thank you, Jennifer.
I am conscious of the time, and I'm going to try to be fast. I'm very happy to be here, and I am going to tell you a story. And I think the story is important because in that first series, we were doing the work for years without any idea that there would be a series. So, and yet that series seems to have lent structure and content to all the subsequent series that we've been hearing about. So what was happening? Well, there were three streams of work going on around 2000, and they included the epidemiology stream, which was led by Bob Black, even then, and Actually, it was groundbreaking because the goal was to use evidence to assign causes of death. Can you imagine? We didn't have a system for assigning causes of death. This became paper 1 in the series. The second team was the program evaluation team, looking at the integrated management of childhood illness. And in 7 countries, led by Cesar, we worked with research teams to actually look at IMCI on the ground and try to figure out what was going well and what wasn't. And then there was the equity stream. And that was a bit separate and was trying to describe levels of inequity in child health and child survival. That became paper 4. So 1, 3, and 4. We're going along, and as the results came in, quite frankly, we got angry, quite angry. Why? Because, as you've heard, kids were continuing to die from causes for which we had interventions, we had affordable things that could be done. In the program evaluation stream, in IMCI, we had a technically perfect strategy, but countries were struggling to implement it. They really were having trouble. And equity, well, we were learning that poor children and their families were missing out, but at that time, nobody was even talking about it. So here we are, and a young editor at the Lancet, Sarah, right there, tracked Cesar and me down and in New York, and we sat down and shared our findings with her. And together we tried to plot how to get things to change, how to disrupt the status quo. So Sarah brought up, as Richard has explained, the idea of a series in the Lancet and made the connection to Richard. Cesar and I brought in Bob Black and we conceptualized the papers. The Rockefeller Foundation agreed to hold a week-long meeting. This was a big deal then. It wasn't something that happened all the time, at the Bellagio Center to try to bring those streams together. Et voila, we hatched the Child Survival Series. The slide, please. There is a slide. There. Try to make it big, please. On the left, you see the group that was together at Bellagio. On the right, you see the series, which Richard flashed, based on a graph developed by Saul Morris. I think it's important to say that the process of doing the series itself was catalytic, technically. As soon as we started putting those papers together, we realized we were missing an essential link. We were not ourselves taking a stand on what should be prioritized or how among the various interventions. So we decided, let's take it on. So we did. For each cause of death, we looked at what was the evidence country by country of interventions that, if taken to scale, could prevent the most deaths. And we, in the end, if you can believe this, it was Herculean and there was a lot of grumpy times there in Bellagio, but we came out with 19 interventions. It was bloody, but we knew we had to get to a workable list that somebody could implement, that they could manage, and that they could monitor. So that's what we did. Now, others have spoken about their perspective on what the series might have done, and I mean, I need to be humble in some way, but at least if it contributed, that's wonderful. What's my take on what might be elements that made it effective? Alliances, Richard has addressed that. I'm going to skip it because of time. But joining the union with the Lancet was incredibly influential, and not just because of who we could reach. There's a drive, there's a passion, there's an inspiration there that made a huge difference. Second, we focused. We really forced ourselves to focus, and I think being able to have a short list made a huge difference. Country leaders told us they needed that list to make plans and resist pressures from donors and interest groups. And there's even papers documenting that. It was a tool, it was power for them. And third, we had a monitoring strategy, and we were fortunate to join hands with UNICEF, with Richard, Countdown, to make that monitoring strategy stick for every 2 years. So there you go. We had alliances, we had an action focus based on population level impact, and we had a strong monitoring component. So for the current season, it's very intimidating and very overwhelming, the number of interventions and the strategies and all. And I know, talking to the authors, that they know that the next step, as Maureen has said, is to focus, prioritize, and make sure that what comes out will turn into action. But I am sure you can do it. Thank you all very much.
Thank you so much, Jennifer. It's so amazing to have you here and to have your perspective. Looking back is so vital for us to be able to look forward. I want, though, to comment that in so many respects, the conclusions and the, let's say, the advocacy of this series 20 years later feels very similar to 2003, that there is a real frustration with lack of action on child survival, and now we know the evidence is clear. So I'm going to put the very difficult question to Tees, because whilst you weren't involved, I don't think, in the first series, you have worked for many, many years in the field as a researcher, but also, of course, in the multilateral space. What is the block? What is it going to take for this action and implementation that everyone in this room has been called for, now that the evidence has been laid out so well by researchers?
Yeah, I mean, the first thing that sort of occurred to me in reading the papers again is that it's actually quite a sobering picture that's been painted here. 6% of late pregnancies die before the age of 20. Inequalities cannot really be overcome through the longitudinal studies. There's a big gap in evidence, particularly after the fifth birthday, and the quality health systems are still far away. So that's quite sobering. At the same time, we should keep the positive picture in mind. Mortality has been thundering down, and it's also over 5 that the declines are not so visible, but they have declined without too much effort. Poverty has reduced, education, particularly girls, has gone up, and also fertility has been coming down in many places. And it does make a big difference if we're dealing with families of 6 children or 2 children, or whether, and more importantly, 30% of the population in a country is under 20 or 15%. That, I think, is already something positive. And we seem to know what we need to do, but it's so big. Life course perspective, multi-sectoral action, survive and thrive, mental health and physical health. So it's perhaps not a surprise that countries and international agencies are quite slow at making the changes that are there. And it's only piecemeal action that we can see here and there. And I think the COVID response, in a way, is a bit symptomatic of that, because I saw very few places or countries or international partners that could make a choice between, on the one hand, protecting those who are most threatened by the infection, the older population, and protected those who are most affected by a stringent response, the younger population. That I haven't seen. And I think that's what we're dealing with here as well. So, I mean, your question sort of, I always get into the monitoring, and I thought Jennifer had a nice sort of way. It had to be simple. It can help with guiding, it guides resources, and it's the necessary accountability. So MDGs were a great example of how to do it. And basically, there were only 2 indicators that resonated with political leaders: maternal mortality and child mortality. They didn't know any of the others. That was it. And those were monitored, and those actually did the job. So now let's look at the science response to this challenge, the SDGs in the Child and Adolescent Health Agenda. 2 responses: indexes and dashboards. So we're creating indexes are flourishing. I mean, there's a child flourishing index, there's an SDG index, pages and pages of the Lancet, countries with how they're doing, confidence intervals on indexes. The other one is dashboards. Every single aspect of child and adolescent health has a dashboard, from maternal health all the way to sexual health, and etc. And on each dashboard, there's maybe 25 indicators or so. So is that what we want? I'm not saying the indexes and dashboards are, futile efforts. They're good. But the point is, we have to come up with something that's simple and sticks with presidents and others. And now I'm also going to disagree with Richard. I think survival is still the best indicator, not because survival should be the focus of everything, but because it's such a good indicator of everything else still. But you also need things around stunting or nutrition, the things that Bob showed, and around education with a strong gender lens. And those three are still, to me, the core. That doesn't mean they're an index of everything else. So let's keep it simple, because this is a mighty complex subject.
Thank you. Thank you, Tees. Well taken. I think it would be fair if we took a question from our online audience, since we haven't had a chance to do that. Alex, can you throw us a question at the Zoom chat?
And should I use the mic?
Yes, that'd be great. Thank you.
So this is a question from Binti ACR Danin Samari from HSE University in Indonesia. And she asks, here in Indonesia, we have problems with stunting. It grabs government attention because they say that stunting problem will impact on 2 to 3% of the GDP. I think it's very serious, regardless of the number of GDP, but it affects the human capital development. Do you know how to overcome this issue, the most effective one, perhaps?
Who would like to take that? I think, let me throw it out to one of our series super authors. Bob, thank you. Yeah, come to the podium, please.
Yeah. Certainly, stunting is a strong motivator for government action, and the economic potential is one aspect. There are many other adverse consequences of the undernutrition, both fetal undernutrition and in early childhood, for development and for actually risk of chronic disease. So, I think you have to address it again across the life course, perhaps intergenerationally, but certainly during pregnancy to ensure healthy growth of the fetus, and especially in early childhood, where, as I showed, that's when the growth faltering is occurring. And if you don't address it then, you have problems that are still there later in childhood and adolescence.
Thank you. Yeah, thank you, Bob. Do we have another question from the online audience?
So this is from Mona Gadardirian at McGill University, and she says, thank you for the wonderful presentations. I had a question regarding adolescent health and nutrition. I noticed how most research and interventions on adolescents are school-based. I'd love to hear your thoughts on how we can best reach and include adolescents that are not attending formal schooling, especially in areas where the internet is not readily available or used.
Great question. Who would like to take that one?
Yes,
Tyler, I can't see you behind the phone. Yeah, please come on up. We probably haven't talked enough about adolescents today, unfortunately, in our short time frame, but please do take that. Thank you.
Yeah, in terms of adolescent nutrition outside of schools, I think some of the strongest effects that I've seen from the systematic reviews that we looked at were for nutritional supplementation and kind of addressing anemia with iron and multiple micronutrients. Also, as I mentioned, interventions to address neglected tropical diseases, they have run-on effects on adolescent nutrition as well. So I think community-based strategies are really important for addressing all of those children and adolescents that are not captured by the school programs that we would be recommending here.
Thank you. So we're very short on time. I think we'll finish with one final question, and that's to you, Jennifer, if I may. So one thing you've really emphasized is how critical the partnerships and the alliances were, and in particular, you reflected on how vital that early connection to the Lancet was. And I know that you and Richard have talked about how it represented a way for a medical journal that had largely seen itself as a publisher of scientific work could incorporate the advocacy that flows from evidence such that your group was generating. So now that you've looked back, and now that you've read the new series, what do you want the Lancet to do in order to revitalize the child and adolescent health agenda going forward?
Here's a question. I think that it's important, and I think Richard embodied it today, I'm a bit naive and outside, but to understand the role of the Lancet is multifaceted. Richard has made himself extremely unpopular, at times with me, by taking up particular causes. On the other hand, there is a voice and an inspiration there. I tried to point to the fact that the Lancet was instrumental in shaping the content of that series, both from the start, when Sarah and Richard, we would have meetings with Richard and he would say, so what? So what? Or, I'm looking to my colleagues here, excuse me, but they made us practice our talks. And we had a wonderful communications guy who basically said to us after our first practice, you people are all professors and you are boring. And then he worked with us. How to present, how to communicate, how to tag it to politics, while still remaining independent with integrity. If the integrity of the Lancet should be jeopardized, I think we are sunk. So, I mean, that is a job, that is your job. On the other hand, you have the science of communication, the science of broad political vision that many scientists, or at least me, I didn't have that. I didn't see what buttons to push. That's you. So I think that's why it's magic, and other editors that I've worked with over the years, you know, maybe they have more integrity or whatever, maybe people are mad at you, but they don't have the impact because they say, oh no, we can't touch that. Now somebody's already done that, or we don't want to get, maybe it's, you know, don't. Richard says, bring it on, let's go, let's fight. And I think there's a huge value in keeping Lancet in that high integrity, but communication and policy attuned role.
Can I stress partnerships as well?
Yeah.
Because do you remember the countdown books we used to use?
Yes.
And on the back page were the logos of all the institutions that we worked with, and the whole, I mean, there must have been 40 or 50.
42. 42.
Right. That was the power. That was the power of what was started back then, and it's an important lesson for us now, actually. That's true. That if we're going to take this agenda forward, we need to be building a coalition, a partnership, a new set of partnerships, because none of us can do it on our own. No multilateral can do it on their own. So how do we do that? So that was one of the key. That was one of the proudest things, actually. That back page.
I think we have to think in terms of carrots too. And I'm sorry, Lancet is a carrot for some people, but that back page was a carrot and became important to ministers.
Yeah.
Because they wanted to be perceived as progressive. So I totally agree with you.
Thank you. I mean, it's a really wonderful way to end, both an acknowledgement of the importance of partnership and what we can do well together, but also a sense of forward movement in terms of how to push this agenda forward, which is with new alliances and coalitions. Thank you all for being here, and wonderful to see you, and I hope this is just a beginning of a continued dialogue. For those of you online, thank you very much. It was 800 people registered, so I hope every single one of you is still here 10 minutes after the hour. Sorry for keeping you, but please do interact with us. We want to hear your feedback on this series. As I said, it's available on Lancet.com. Thank you to everyone. And with final remarks, the series coordinator, Zulfiqar Bhutta.
Thank you, Jocalyn, and it's okay to go a few minutes over time because we started a little late, and I know there have been a number of people online, but I can't finish this session today without thanking a number of people who made this possible. So first of all, I want to thank the people who supported the series, both materially and in terms of lending it their support, and they include my own centers, the Center for Global Child Health and the Aga Khan University that provided core support to this work, to the Gates Foundation for providing a lot of the core support to the work of many of the series papers, to IDRC for supporting the important work on school age and young adolescent evidence reviews, and the World Health Organization for helping us do the platforms work, and to Countdown for 2030 to coming to our assistance at the time when we needed it most. To the Rockefeller Foundation for helping us assemble in Bellagio. So a number of people need to be thanked. I want to particularly thank the Aga Khan University and its support staff for hosting this today, to Alexandra Khan, Martha Galway, Wahab Gofrani, and Donmai Kowasti in the comms team. And at SickKids, Hannah Scott and Dana Als, who provided a lot of the coordination. At the Lancet, the comms team led by Johanna Harvey. And a special word of thanks to the young people behind a lot of the papers, and particularly Tyler Vaivada, who represents a whole group of the next generation who will take this forward. Thank you very much for being here, friends, and we look forward to seeing you soon as we begin the process of walking the talk. Thank you.